Our speaker is a graduate of the University of Santo Tomas. She did her residency training in internal medicine at the AFP Medical Center and her residency training in Dermatology, Skin and Cancer Foundation. She obtained her fellowship training in venereology at the Philippine Society of Venereologists, Inc., and attained her master's in internal medicine, major interest in diabetes at the Institute for Studies on Diabetes Foundation, Inc. To discuss dermatologic manifestations in diabetes, please welcome Dr. Liza Marie Paz Tan.
Hello, a good day to all of you. I'd like first to thank Diabetes Philippines for this invitation to talk to you on this also a very important topic. So allow me to share my slides and we'll start with the lecture or the discussion. So I'm going to talk about dermatologic manifestations of diabetes. As a disclosure, I am mainly a private clinician, but I also have a part-time status at the Mariano Marcos Memorial Hospital and Medical Center in Batac City, Ilocos Norte. I am likewise an associate professor, College of Medicine of the Mariano Marcos State University. And as a disclosure, I speak also for pharmaceuticals in both diabetes and dermatology, mainly here in Ilocos. As part of my presentation, my objectives for this lecture is to familiarize everyone in the audience, especially diabetologists, with the different dermatological conditions associated with diabetes. And with this knowledge, you would know when to refer to a board-certified dermatologist. And the outline of my talk would be as follows. We're going first to talk about skin manifestations strongly associated with diabetes, non-specific dermatologic signs and symptoms, dermatologic diseases associated with diabetes, and the cutaneous changes associated with diabetes medications. First, we're talking about the skin manifestations strongly associated with diabetes, and these are as follows, and we will discuss them. I will show you some pictures one by one. First is acanthosis nigricans. So you would have observed this in most of your diabetic patients. It is more common among type 2 diabetic patients and more prevalent with darker skin color. So this is where we belong. But it's not only with diabetes that acanthosis nigricans is observed. It is also present in other endocrinopathies such as your polycystic ovarian syndrome, thyroid dysfunction, acromegaly, Cushing's syndrome, and likewise in malignancies such as gastric adenocarcinoma. So you would have observe this with your patients when you see their name, when you do your examination already. You would note that there are multiple poorly demarcated plaques with gray to dark brown hyperpigmentation, and the texture would be a thick, velvety kind to a verrucous, meaning it's a relatively rough texture. And patients would tell you that it has been there since as far as they can remember. Most of the plaques are symmetrical, but they are asymptomatic. It's just more of the cosmetic appearance that patients would come to us dermatologists to alleviate this malady. Most of the time, these are on the intertriginous or flexural surfaces. So on the nape, the axilla, the elbows, the palms, and these are called tripalms. the inframammary creases, umbilicus, and the inguinal areas. These acanthosis nigricans may be present prior to the clinical diagnosis of diabetes. The pathogenesis is still unknown up to this time, but it has been postulated that the hyperinsulin state of diabetes stimulates insulin growth factors, specifically IGF-1. And these factors stimulates the keratinocytes and fibroblasts, leading to cell proliferation. Treatment, as we diabetologists would prescribe our patient, first and foremost would be lifestyle changes, which include your dietary modifications and exercise. If the patient is overweight or obese, then weight reduction is a must. Employing OHAs such as your metformin will help decrease the appearance of acanthosis nigricans, but it will not really completely resolve the issue. For localized acanthosis nigricans, keratolytics such as your retinoic acid, lactic acid, and salicylic acid may lessen and improve the appearance of these dark plaques. Next condition would be diabetic dermopathy. These are pigmented pretibial patches or commonly termed as diabetic shin spots. This is the most common dermatologic manifestations of diabetes. It is more common in males and for those who are 50 years old and above. This also may antecede diabetes onset, or more frequently, it can be a late complication of diabetes, and it should trigger investigation for the other microvascular complications and neuropathies. Diabetic dermopathy develops independent of glycemic control, meaning even if patients present with good glycemic control as exemplified with uh, A1C of 6% and a glycomark test of about 10%, they would consult you and tell you what are these brown spots on their shins. So it would start as a dull red papule on the anterior tibia and would progressively evolve over 1 to 2 weeks into circumscribed atrophic brown macules. They are usually bilateral and seen over bony prominences such as your pretibial area, the forearms, lateral malleola, and the thighs. There's no need to do skin biopsy on this as the histology is always non-specific. This diabetic dermopathy is really asymptomatic and self-resolving. And next, skin manifestation highly associated with diabetes is diabetic foot syndrome. This usually encompasses the complications of neuropathy and vasculopathy of diabetes. It is actually a preventable condition. However, patients would not disclose neuropathic symptoms, and they would not correlate that this would later lead to graver circumstances. So diabetic foot is a significant cause of morbidity, mortality, hospitalization, and reduction in the quality of life among diabetics. It is usually seen in 1 to 4% of patients and has a prevalence of 4 to 10%. However, we are seeing more and more of these cases already. Diabetic foot syndrome would always entail interdisciplinary team-based approach. So the focus, as in all other complications of diabetes, is prevention. So we should advise patients to every day see their feet. And if they cannot see because their vision is already impaired, then their significant other in the house should do it, the surveillance for them. Patients should always wear appropriate and proper footwear and always do appropriate foot hygiene also. When ulcers are already present or even just abrasions before they become ulcerated, patients should be advised of appropriate wound care program, antibiotic therapy if necessary, and if the ulcers become more progressive, then wound debridement should be in place. Eventually, patients would need to undergo further diagnostic tests to check on the vasculature, and then there may be a need for surgical revascularization or bypass if there is still a need to save the foot. Most often, patients would come to us and we would be at a loss also in saving the foot. So it would start as callus and dry skin, which is related to neuropathy. And later, there would be chronic ulceration already and malformations. If the ulcers are painless, then it's predominantly of a neuropathic cause. But if it's painful, then ischemia is present also. So the complications of diabetic foot inevitably is secondary infection. Malformations of the foot would lead to neuroosteoarthropathy or the Charcot foot, which is on the lower picture. Prominent redness, warmth, and burning pain of the foot would be a complaint of the patient, and this is termed as erythromelalgia. So it would worsen with exercise or heat exposure. As we have often seen and heard, the International Working Group on the Diabetic Foot has set these guidelines in 2019, and this should be kept in mind when we see a patient with this diabetic foot, because it will also help us in the prognosis, and this would always entail a multidisciplinary approach in order to save the limb. So the pathogenesis in neuropathy, there would be an initial demyelination of the nerves. So the patient would have blunted perception of adverse stimuli with reduction in sweating, and patient would be prone to fissures and secondary infection. Just this morning, I had a patient who had been complaining of thickness, feeling of thickness on both feet, that he did not feel that there was already a glass or a small glass embedded in on his foot. That was a month ago, and so today he came with really severe cellulitis. Okay, so the other pathogenesis for pathogenic or for diabetic foot syndrome would be presence of atherosclerosis. So as we have learned, atherosclerosis starts when we eat those precious four-legged animals, and it aggravates or progresses up to the time that we enjoy retirement. So, and then because of diabetes, there would be impaired wound healing, in that there is impaired macrophage function, and there is always increased and prolonged inflammatory response in a diabetic patient. Hyperglycemia aggravates all of this pathology. In hyperglycemia, there is increased advanced glycosylation end products, and there are pro-inflammatory factors aggravating the already increased oxidative stress. Next, condition that patients would with diabetes would complain of is presence of thick skin. Hindi po yung makapal ang mukha, iba po yun. So diabetic thick skin would entail thickened, waxy edematous skin, which may be asymptomatic or reduced in sensation, or the patient may complain of pain also. These are most commonly noted on the hands and feet and may represent scleroderma-like changes or limited joint mobility, which are the next changes that are commonly associated with diabetes. So scleroderma-like skin changes is more common in type 1 diabetes. Remember that autoimmunity is also high in type 1 diabetics, but also present in type 2 diabetics. That's why we also see these scleroderma-like skin changes among the adults. So these are bilateral symmetrical painless indurated plaques, more commonly seen on the dorsum of fingers, the ITPs and the MCPs, on the hands, and then there would be progression to the arms and also to the back of the patient. This would note or be associated with the increased risk of developing both nephropathy and retinopathy. So if the patient would come to you and show these skin changes, then we need to investigate further on the kidney status and the retinal status of the patient if not yet investigated. Because of these scleroderma-like changes, patient would have limited joint mobility as well, with progression further to Dupuytren's contracture, which is the presence of palmar fibromatosis and the trigger finger or stenosing tenosynovitis. So as you have part of the physical examination, we would ask the patient to do the prayer sign like this. And if their fingers are not opposing, then it would be because of the scleroderma changes on the dermis. So the pathology is strengthening of collagen due to reaction with the advanced glycosylation end products or sugar alcohol buildup in the upper dermis. When we do skin biopsy, there would be thickening of dermis with minimal to absence of mucin and the increased interleaking of collagen. Treatment would still entail tight glycemic control. One may use aldose reductase inhibitors, but if the patient would have contractures already, then physical therapy and surgical release of the contracture is in order. Limited joint mobility shares pathology with scleroderma-like skin changes. Limited joint mobility is also termed as diabetic chiroarthropathy, and majority of patients with this would also complain of scleroderma-like skin changes. It is present in about 8 to 58% of diabetics, but it can be present also in 4 to 26% of patients without diabetes. There is progressive flexed contractures and hinder joint extension of the MCPs and the IP joints. So when we do the exam, we ask the patient to do prayer sign and also the tabletop sign, wherein you ask the patient to press on the top of their table, and you see that patient would not really compress the palms on the tabletop. So there is presence of periarticular enlargement of the connective tissue. This manifestation is strongly associated also with microvascular and macrovascular changes. So the presence of the AGEPs promotes inflammation, formation of stiffening cross-links between the collagen. Treatment would still be glycemic control. And for symptomatic relief, we should be cautiously giving NSAIDs, but patient would or might need intra-articular steroid injection also. We do advise patients to do regular stretching to avoid the contractures, and there may be later need of referral to a physiotherapist. Another common scleroderma-like change in diabetes is termed as scleridema diabeticorum. So this is a gradual worsening indurated and thickened skin, meaning it's a worsening of the scleroderma-like skin changes. The plaques would be symmetrical and diffuse except for the distal extremities. It is usually asymptomatic, and patients would complain or tell you that there is reduced sensation on the affected areas. On skin biopsy, there would be increase in the collagen, thickened reticular dermis with mucinous infiltrate, but there is no edema noted. The pathology would be an interplay between non-enzymatic glycosylation of collagen, and decreased breakdown of collagen. And so treatment would be difficult for this patient because this condition is unresolving and progressive. One may employ immunosuppressants, oral steroids or parenteral steroids. Because of the autoimmune pathology, one may try to give intravenous immunoglobulin, but this is not always successful. Patients may be subjected to phototherapy with Soralen or PUVA, and with the increased contractures, patient would also need physical therapy. Another condition we most often encounter with diabetic patients is this condition, necrobiosis lipoidica. This is a rare but a chronic granulomatous disease. Patients would complain of single initially and then group, firm, well-demarcated, rounded erythematous papules and evolution into plaques with circumferential red-brown distinct borders and firm yellow-brown waxen atrophic telangiectatic center. This is usually asymptomatic, but patient may complain of hypoesthesia and or pain, especially in the presence of ulcer. So the presence of hypoesthesia would make you think also of a common skin condition in the Philippines, which is leprosy. These are usually bilateral, and there is kebnerization. Kebnerization would mean that patients would develop the same lesions on areas of trauma. Even on minor trauma, this would lead to kebnerization also. Sites of predilection would be the pretibial areas on the lower extremities, but this would also develop on the scalp, the upper extremities, the face, and the abdomen. So we need to do skin biopsy on these cases, and it would present with the findings of palisading granulomatous inflammation, necrobiotic collagen, a mixed inflammatory infiltrate, reduced mucin, and thickening of the blood vessel wall. There is a strong predilection for women of necrobiosis lipoidica. It may be present 1 year after the diagnosis of diabetes, but there are some patients in about a quarter or 24% that these findings occur prior to the diagnosis of diabetes. The real pathogenesis is unknown, but this is related to the microangiopathy of diabetes. So there are irregularities in the collagen. This is also associated with other autoimmune diseases and with abnormalities in neutrophil chemotaxis. Treatment, this is one of the steroid responsive skin diseases. So at the start, one may employ mid-potent topical steroids, but when it worsens, oral steroids would be needed. So when oral steroids are needed, you have to check for the glycemic control of the patients. If the lesions are very thick, then we can do intralesional injection also. Other treatments that may be needed would be your calcineurin inhibitors, your anti-tumor necrosis factor inhibitors, pentoxifylline, and your antimalarials. When necrobiosis lipoidica is severe, one may also refer the patient to a phototherapy unit for PUVA. In the presence of ulcers, appropriate wound care would be needed. If a diabetes control is not good, then we need to do glycemic control or achieve glycemic control. But achieving glycemic control does not correlate with resolution of this condition. Another more common finding that you may have encountered in your diabetic patients is the condition of bullosis diabeticorum, meaning patients would complain to you of a vesicle or bullae suddenly appearing on their feet. This is associated with the complications of neuropathy, nephropathy, and retinopathy, usually occurring in the males between 50 to 70 years old. Usually, patients would complain of an abrupt onset of sterile bullae bilaterally, but this would resolve spontaneously and it would heal. Um, Lower extremities are often the sites of predilection, but it can also occur on the arms and the trunk. Histology is non-specific, so but there is still a need to do skin biopsy of these patients, especially in the elderly, because we need to rule out the primary bullous diseases in the elderly, such as your pemphigus vulgaris and your bullous pemphigoid. So the pathogenesis of this bullosis diabeticorum would be an autoimmune process, excessive UV exposure, glycemic variability, presence of neuropathy, and microangiopathy. Sad to say that treatment there is no one treatment for this, but when patients would accidentally puncture the bullae, then we need to do advise the patient to apply immediately a topical antibiotic ointment and caution them to avoid having secondary infection on this, because it will lead to the other graver circumstances already. So we now go to the non-specific dermatologic signs and symptoms, and these are quite a number also, and you may have noticed this also in your patients already. So first and foremost are the ichthyosiform changes of the shins, which you may see as fish-like skin on the anterior tibia of the patient. This is related to rapid skin aging and adhesion defects in the stratum corneum, both of which are associated, or the skin changes in their diabetic patients. This is related to the production of your advanced glycosylation end products and to microangiopathy. Treatment would just be topical emollients, preferably paraben-free and perfume-free. So the patients really, and you also as physician, the diabetologist would need to advise patients to read on the ingredients, and these are the primary ingredients that need to be avoided because they can induce contact dermatitis also on the patient. So next would be your cirrhosis, which is a graver form of the ichthyosiform changes. So this is an abnormally dry skin wherein there are coalescing patches with exfoliations, and sometimes this would lead to fissures. This is related to microvascular complications also, and treatment would be the same. That is frequent use of emollients. Patient would complain to you of pruritus or itchiness, and just advise the patients that they need to have the lotion on their pockets also. So whenever they need to scratch, instead of scratching, they just apply the emollient. And we also need to prevent secondary infection. So just to inform you, scratching would already induce microscopic abrasions of the skin. So to avoid this, you need to apply emollients also. Another graver condition associated with diabetic patients would be acquired perforating dermatosis. So this is more commonly observed with diabetic patients who are already on dialysis, or for those with a long term, like 30 years with diabetes. So patients would come to you when they are in their early 30s or as late as 90 years old. A description would be these are hyperkeratotic umbilicated papules and nodules with a central keratin plug. These also occur on areas of trauma. So this is termed as positive kebnerization. Patient would complain of extreme pruritus. This APD is associated with glycosylation of the microvasculature or the dermal components also. And there is accumulation of immunogenic substances not eliminated by dialysis, and this is aggravated by chronic scratching. So the first and foremost treatment would be antipruritic medicines, which may be your oral diphenhydramine, your chlorpheniramine, or patients would need also topical keratolytics and steroids also to reduce the associated inflammation. When the papules are really and nodules are really very thick, we can do intralesional steroids also. Patients may undergo cryotherapy and PUVA. But the another foremost treatment for acquired perforating dermatosis would be effective management of the underlying disease. Another condition that would patients complain because of cosmetic concern would be eruptive symptoma. This is the clinical presentation of hypertriglyceridemia, especially with the serum triglyceride reaching to 2,000 milligrams per dl for non-diabetic patients. Diabetic patients would have even lower, less than 1,000 level of your serum triglyceride. It is prevalent in 1% of type 1 diabetics and in as many as 2% of your type 2 diabetics. Patients would notice that there are eruptions of glossy pink to yellow papules with an erythematous base, usually on the extensors of either the upper extremities, lower extremities, or both, and even in the gluteal areas. This is also associated with kebnerization. So you would notice that there is a linear uh, uh, formation of your papules denoting the trauma because of scratching. So on histopathology, there are noted foam cells with the mixed inflammatory dermal infiltrate. Treatment, of course, your glycemic control and reduction of your triglyceride levels. We do laser therapy for these skin conditions, but we advise the patients to have control of their blood sugar as well as their triglyceride levels. Acrocordons is also a common complaint of patients, whether they are diabetics or not. So these are soft benign fibromas or skin tags, the layman's term for these fibroepithelial polyps. These are commonly noted on the neck, axilla, and periorbital area. So the treatment would be surgical, either by excision, cryotherapy, electrodesiccation and cautery, or the use of the vaporization with carbon dioxide laser. So this is another cosmetic concern only. Diabetes-associated pruritus is also a common complaint of diabetic patients, more often localized, but it can be generalized, initially occurring on the scalp, and then patients would claim pruritus also on the ankles, the feet, trunk, and genitalia. So this is more likely in the setting of dry skin or even diabetic neuropathy. Treatment would be topical capsaicin, which is still not really readily available in our country. In the setting of extreme pruritus, we can also give the oral anticonvulsants we give to neuropathy, such as your gabapentin and pregabalin. In the presence of fungus infection, then antifungals is necessary. Huntley's papules, these are the finger pebbles. These are benign clusters of non-erythematous papules on the dorsum of hands, especially noted on the MCP joints and periungual areas. This may be an early sign of diabetic thick skin. So This is a cosmetic concern, and treatment is related to glycemic control. Another concern is keratosis pilaris, which are keratotic perifollicular papules with surrounding erythema, or if chronic already, there is hyperpigmentation. These are usually noted on the posterior surface of the upper arms, the thighs, and even the face, and also in the gluteal areas. It is more frequently seen and extensive in diabetic patients. So when the patients would complain about this, emollients would be necessary. And then if it is as worse as this picture that we see on the screen, then keratolytics may be prescribed on the patient. So what are the keratolytics needed? Then you would refer to your partner, the board certified dermatologist. Another concern would be the purplish macules and patches initially noted on the lower legs, especially on the pretibial areas. So these are your pigmented purpuric dermatosis, or which are pigmented purpura. This may be associated with pruritus, or the patient would just come to you asking what are these red spots on the legs. Usually the patients are geriatrics already, and patients would also present with diabetic dermopathy. So as has been mentioned before, this is associated with nephropathy and retinopathy because of the microangiopathic capillary damage and sequential erythrocyte deposition. Another would be your palmar erythema. So this is similar to the palmar erythema we see with patients uh, having liver conditions. So these are symmetric redness and warmth of both palms, especially the hypothenor and thinner eminences. These are usually asymptomatic, but this is an evidence of microvascular complication of diabetes. Presence of periungual telangiectasia is another microangiopathy due to diabetes. So this is because of the venous capillary dilatation. You would note, or the patient would tell you, that there is redness surrounding the proximal nail fold, and you would notice erythema and presence of telangiectasia. These are usually asymptomatic, but patient may also complain of finger tenderness. So that would be a clue that there is neuropathy already. Patients would notice also that the cuticles are becoming more rugged. So that's part of the microangiopathic picture or pathology of diabetes. Another would be redness of the face or chronic erythema of the face or even the neck, which is termed as rubeosis faciae. So there would be presence of or absence of telangiectasia, but it's more of the presence actually, because it is secondary to small vessel dilatation and microangiopathic changes. This is associated with the presence of the complications of retinopathy, neuropathy, and nephropathy. So this improves with better glycemic control, with reduction of caffeine and alcohol. So you would make booking to the patient that he would have still, especially if you're having the male patients, that he would still be having alcoholic intake. In Ilocano, we term this as sweetie. So the patient is lying that he is not taking alcohol if you see the redness of the malar areas. So presence of yellow skin and nails is also related to diabetic skin changes, more often seen in elderly diabetics. So this would be yellowing of the palms, the soles, the face, and the distal nail of the first toe. However, this should be differentiated from a beginning psoriasis, which also entails yellow macula on the nails, or associated onychomycosis, or tinea unguium or fungus infection of the nails. So this is related to accumulation of the various substances such as your carotene and the glycosylated proteins. So we have the last group that we'll discuss are the dermatologic diseases associated with diabetes. So have you counted the many skin changes that you will need to check the next time that you see a diabetic patient? Okay, so granuloma annulare. In diabetic patients, this is usually generalized. So it would be distributed in nearly discrete areas of the body of a diabetic patients. And this is associated in 10 to 15% of patients with diabetes, more commonly in females, but males are not exempted with this condition. So it would start as a group of flesh-colored or erythematous firm papules slowly growing and become centrally involuted, meaning the center of the affected area is noted to be atrophic. So there would be hypo or hyperpigmented annular rings with elevated circumferential borders. So the differential of this would be your leprosy, psoriasis, even your ringworm or tinea corporis. This is bilaterally distributed on the trunk and extremities and usually asymptomatic, but may still be associated with pruritus. Pathology would be activation of your lymphocytes through delayed type hypersensitivity, initiating pro-inflammatory cascade and granuloma formation. So we need to do skin biopsy of these cases. Treatment would be employing the antimalarials, retinoids, dapsone, and even cyclosporine, and your corticosteroids. Note that cyclosporine have nephrotoxicity, and in the presence of diabetes, a chronic diabetic condition would be aggravated with when you employ cyclosporine. When you use or when the dermatologist already prescribed oral steroids, then you need to be cautious in the glycemic control of these cases also. Patient may be subjected to PUVA. So I hope that in your practice you have a phototherapy unit nearby or that you can refer to. Psoriasis also associated with diabetes. In my early practice, which is just a few years ago, um, I have noted this association already, and in time there was already cemented association of psoriasis with diabetes, mainly because both of them have autoimmune pathology. So psoriasis is a chronic immune-mediated inflammatory skin condition associated with hypertension, metabolic syndrome, and diabetes. Lichen planus is also another condition associated with psoriasis wherein there are violaceous papules which are firm polygonal even on the mucosal area. So, and also seen on the wrist, ankles, trunk, back, and thighs. So we need to do skin biopsy on both psoriasis and lichen planus. Vitiligo. It is another acquired autoimmune disorder involving melanocyte destruction. So there are scattered hypo or depigmented macules initially on the acral areas going centrally. Females and type 1 diabetics are commonly afflicted with this because of the autoimmune pathology. Another condition would be your hidradenitis suppurativa, which are chronic inflammatory nodules and abscesses on the axilla and inguinals. Patient would complain of recurrent painful and malodorous nodules on the axilla and inguinals, which are complicated by sinus formation, resulting in disfiguring scars. Treatment would be, of course, your antibiotics, and you need to refer to a dermatologist to employ retinoids and antiandrogens, and also immunomodulators when the antibiotics are not enough to control this. Glucagonoma. This is a rare neuroendocrine tumor and usually appears on the sixth decade of life with non-specific symptoms. So 70 to 80% of these patients would present with necrolytic migratory erythema as shown on the picture. So there are erythematous erosive crusted papules initially, and then becoming to vesicles, plaques, and evolving to bullous formation with irregular borders. The differential diagnosis of this would be your bullous pemphigoid condition. So skin biopsy is needed on this to differentiate between the two. This may be just pruritic or even painful for the patients. And diabetes would precede the diagnosis of glucagonoma in 20 to 40% of cases. Histopathology, there would be presence of epidermal pallor with necrolytic edema and numerous perivascular inflammatory infiltrates. So last but not the least are the skin infections. I think this is the most common presentation of a diabetic patient. Either this would lead you to the diagnosis of diabetes, or this would be an impetus for the patient whom you have not seen for a long time, and then he would follow up even in this pandemic condition because of uh, skin infections not resolving with their self-medication. So this would be present in about 25% of diabetic patients, and diabetic patients are more prone to repeated infections. The factors leading to recurrent skin infections would be the following: angiopathy, neuropathy, hindrance of the antioxidant system, abnormalities in your leukocyte adherence, abnormalities in your chemotaxis and phagocytosis, and of course, having a glucose-rich environment facilitating microbial growth. So this would be in two major groups. Either patients would come to you with bacterial skin infections or fungal skin infections. More commonly in the bacterial skin infections are erysipelas, cellulitis, folliculitis, carbuncle, perifollicular abscesses, the diabetic foot infection, necrotizing fasciitis, Fournier's gangrene, erythrasma, and even malignant otitis externa. For the fungal infections, more commonly your candidiasis, whether the oral thrush or in the intertriginous areas, dermatophytic infections on the intertriginous areas also, which would lead to your serious conditions, which are secondary bacterial infection, fungemia, and sepsis. Morbid fungal skin infection would be your mucormycosis, which would lead to sepsis, and if not brought to you immediately, then it may be of poor prognosis. So in the interest of time, I would this would be your assignment. So, and I think you very well know this already, that you can easily treat these skin infections already. So we need to discuss also the cutaneous changes associated with diabetic medications. Remember that these are still synthetic molecules that can trigger either delayed or immediate hypersensitivity in our diabetic patients. So for patients who are prescribed with insulin, you would encounter lipohypertrophy or lipoatrophy. Remember that the insulin gets deposited in the subcutaneous fat. So either the subcutaneous fat would hypertrophy or atrophy. And then there would be an immediate allergic reactions or a delayed allergic reactions. So you might encounter patients who would tell you that immediately after injecting the insulin, they would notice bumps on their sites of injection, but which would later resolve in an hour or two. For the oral medications, we would encounter either urticaria, erythema multiforme, bullous pemphigoid, and the worst, Stevens-Johnson syndrome. So we should be aware of the of what we prescribe our patients, and we'll have to caution patients of and to be observant of any skin changes that they would see when we prescribe new medications, even with these anti-diabetic medications. So I hope I have run down to you, and these are my references, the various dermatologic manifestations and conditions associated with diabetes. And if you have any questions, I would gladly entertain them in the open forum. So when we need to get started, we need to quit talking and begin doing. And agyamanak apo, Diyos ti agnina kada kayo, that means thank you in Ilocano.